just so you guys know what happened in the background, Subbio messaged me and said, look, I don't want to come across as some sort of authority on VOs. I just want to like share it. And maybe, I think your exact words were, I think of myself more as a drunk with a strong opinion at a bar. And I'm like, well, I'll be a kid with a stick and poke you a bit and see what I can find out about your way of thinking. Because what I do love about the way you convey things, you quite often latch on to something where there's a general perception of one thing, and you do prick a hole in it, and then it gets everyone thinking. So, and that's what you did with these two cases, really. There's two elements of this one case, actually. So the first is this amazing transformation, which I'll show of someone with a really big VO. But what then you realize, you've basically revealed after, that 96% of people disagree with you about how VOs work.
Yes.
So we're going to start on that, which is where this little quiz came in behind me here. So that's what we're going to lead up to, trying to understand about why Dr. Subbio thinks this vascular occlusion would have no consequence. So it really will get you thinking. So we're going to go cover that towards the end. And then I want to first of all just cover what happened with this young lady and this amazing transformation, this fantastic bit of content, which I will play in the background here.
Seriously, there's no such thing as a small procedure. If you found this interesting,
sorry, starting at the back. We'll get
so this is an interesting case that was sent to me last week. A facial artery blocked by filler. First, understand that the face has a chaotic network of arteries all connected by different branches. Now, if your injector is extremely unlucky and that needle ends up inside of the artery when she begins to push the filler, well, that filler is going to travel all the way up and block the entire artery. If your injector doesn't recognize this, the tissue will lose blood supply, scab over, and die off. Luckily, she did recognize it, so we caught it in time. Here's what it could look like. I went through my entire stash of reversal agent, then borrowed a bunch more from Dr. Bloom. I reversed her that night, the following morning, and the following day. And sure enough, day by day, along with the help of some hyperbaric oxygen treatments, things got better. A week later, and she's almost healed. So look, everything turned out great with her, but the lesson here is take injectables seriously. There's no such thing as a small procedure.
So that is just, on both levels, a brilliant case, but also a fantastic piece of content. Because when I first watched that, you go through this journey of like worrying about it, seeing it, then Dr. Bloom pops out as a nice positive, and then you get this like amazing dopamine hit when she's all healthy at the end of it. So it's just a beautiful 1 minute of content gold, which really, really fantastic. But I want to hear the story behind it and basically what you learned from that case, because I always find with any of these things, with any of these cases, you always end up learning something from it. And that's what I would love you to share with our audience, because they all worry about these things and want to learn about it. So,
sure. I mean, one thing I will say, and like you mentioned, I don't want to be credentialed as some expert on VOs. You know how many VOs I've handled? Guess.
No.
One. That one.
Wow.
Surprising, right? But one thing, so I'm no expert on VOs, but one thing I do want to credential myself on, because I'm looking at 1,800 people tuned in to see me talking about this. I do want to credential myself a little bit in that, you know, I do injectables. I do a lot of funny shit on Instagram, but before all of this, I did a microvascular fellowship in plastic surgery. And like what a lot of people don't realize is plastic surgeons, it's not just all TNA. For the most part, reconstructive plastic surgery is moving tissue, is raising tissue based on blood supplies and looking at blood supply and seeing if is there perfusion? Is it going to necrose? That is all what a reconstructive plastic surgeon does. So to that end, I mean, I have a lot of experience with vessels, with checking perfusion, with operating on vessels, with sewing vessels together. And then, so when this came across, you know, when this call came in, despite the fact that I've never really handled a vascular perfusion, a vascular occlusion or vascular adverse event, I was quite comfortable because I have all the tool sets. I mean, if not me, then whom? So it's, while I'm no authority or expert on vascular occlusions, I can say I do have some expertise in dealing with vessels and perfusion, because that's what plastic surgeons do. And it's one of the things I'm happy that we all bring different things to this field from our different avenues. And I love being a plastic surgeon because that's my wheelhouse. So if I may, Dr. Pierce sent me an outline of a couple questions that we might go over. So of course you mentioned this case. So I'm going to show you a little on my thing here. So let me just back this up. I'm going to try to switch between my iPad and my computer. So let's just go through this vascular and Dr. Pierce, I would like to make sure, like, you know, I don't want to just be talking. Please stop me at every juncture, because most importantly, this is why I didn't just want to do a lecture. I want the back and forth with you, because I respect your expertise so much and the way you think. When we talked in Switzerland, I was so impressed. So I want to hear what questions you have for me, what points, what challenges, etc. Anyways, vascular emergencies. One thing, I was putting this together and I did feel a little bit guilty, because I have so many more illustrations that I'm working on for this vascular talk. So that should be done in like a week or two. So if anyone wants that, just email my wife. Before an hour ago, I'm like, hey, I should, you know, I'm going to send this lecture out to anyone who wants it. I'm not selling it. I'm not trying to make money. I don't want your information. But if you want this lecture, just email me and at this JILLIAN at Dr. Subbio, and we'll send it to you in like a week or two. But on to this particular case, okay? So this was a skilled local injector, okay? Years under her belt, very intelligent, very good injector. And a couple of questions you would ask was, well, how was this injectable done? This injectable was done with a stationary bolus at the pregel sulcus, which of course is the facial artery territory. You asked me as well, what product was it? And that's an interesting question, because of course product matters, but only to a degree. I think it was Voluma. I think I remember asking her what it was. It was either regular Juvederm or it was Voluma. But frankly, and I want to get your thoughts on this, Tim, because you know, it doesn't really matter to me. In the end, some gels are more difficult than others to dissolve. Look, as long as it's an HA, I know what my plan of action is, injecting Hylenex. So it doesn't really matter to me if it's Voluma or if it's Restylane. If she told me Restylane, I'd be like, okay, this thing's going to dissolve a bit more easily. Let's say she told me Voluma. That to me, all that meant to me was, okay, I might need a bit more Hylenex for this. But in the end, it doesn't change what I'm going to do, because in the end, I'm going to keep going until the thing is cleared. So it's not going to change my plan of action. So I think people that, you know, that focus too much on that aspect, it's kind of missing the point in that, look, in the end, I don't care what the product was. As long as I can dissolve it, I'm going to keep dissolving it until it is dissolved. I got to get to that endpoint. But and before we go on, any thoughts on that about products? Any experience on your end about that?
So, I mean, it does, I'm sure there will be a difference between products, because if you change a variable, there'll be some difference. I've had it probably predominantly dissolved Vicross products in my clinic, because that's the one we use the most. And I couldn't tell between the ones that weren't like the old-fashioned Juvederm, shouldn't call it that, and Vicross. It seems to be that there are other variables that make a difference, like how much you injected, where the artery is. So it's very hard to get a strong feeling about whether it's that different. But they were all within the same ballpark. But it does make sense that you would have a difference. But whether the difference matters or not, I'm not sure.
Yeah. Okay. So, so next up, she aspirated, which, you know, like I said, she's a great injector. She aspirated. And if she's going to do the stationary bolus technique, absolutely, she should aspirate. And guess what? There was no flash. It was a negative aspiration test. And because of that, she proceeded. And this is this whole debate about aspiration, which I'm going to get to in a second. Then I want to ask for your thoughts on this. But I believe it was a 0.2 or a 0.3 bolus. All right. So
was this on the bone, or
yes,
do you know?
On the bone. On the bone. So, or at least like what was perceived to be on the bone. In my opinion, once you're under the skin, you don't know where you are. And yeah, if you're abutting the bone, sure. But it was a 0.2, 0.3 cc bolus, which again, you know, this is, well, let's talk about that for a second, the park and push technique. And this is a real, there's a couple things in this discussion that I think are really important. And this is one of them. Anyone that knows me knows I go on ad nauseum about park and push. And that to me means when you're sticking a needle into the face and you are putting a bolus, a significant bolus, and the significant bolus to me means anything over 0.02 or 0.03. Like some people, and this is what I don't get. Some people, not some people, many people, many speakers, many people at the industry trainings, it's still rampant, this idea that you can stick a needle into the face and push 0.2, 0.3 cc's without any consequence. This is the problem, in my opinion. And I don't blame her. She did the right thing. She aspirated. She's doing what everyone does, or what a huge subset of our injectors do. They park and push. They stick a needle in and they start pushing a significant bolus. And ladies and gentlemen, there's two ways that, well, to simplify it, there's two ways that you're going to get a vascular occlusion. One of them is if you stick a needle in and start pushing without moving, the needle, if you're extremely unlucky, is going to be in there and you're going to fill the artery and you're going to cause a massive vascular occlusion. The other is if you are trying to move and you are inadvertently in the artery, you're stuck in the artery unwittingly, and you're going to cause the same thing. That to me represents a minuscule subset of these cases. The vast majority of the danger here is sticking in, not moving, whether or not you aspirate, because as we know, aspiration is not reliable 100%. Maybe it's 50%, but it's not 100% reliable. If you stick it in and start pushing, you are going to have a massive vascular occlusion. And so people, I understand that, you know, it's like a pissing contest of humility. Oh, it could happen to anyone. Oh, I haven't had one yet, but it's going to happen to me at some point. Oh, it could happen to, it's not going to happen to anyone. And that's what I want to tell people. Like, of course, you want to virtue signal and tell everyone how safe you are and how humble you are. But I will tell you, something like this will never happen to me. I would swear on my eyes. That might be egotistical or hubristic, but it's never going to happen to me, because that is the way that you get a giant vascular occlusion, by filling, by parking and pushing and filling that entire vascular tree. And regardless of whether you aspirate, and then I'm going to pause and let you give your thoughts because I want to hear what you think about this. But so parking and pushing to me is the danger here. And again, it happens at all the conferences, at all the industry trainings. You see these famous injectors get up on stage and they stick a needle in, and let's say it is the piriform fossa, one of the most common things I see. If you think you're going to luck out and miss all of these vessels, you're probably right. You know, 999 times out of 3,000. But if a vascular occlusion happens 1 in 3,000 injectables, it's going to happen to you sooner or later, because I don't understand why you can do that and think nothing is going to happen. So this whole debate about whether or not to aspirate, to me, is ludicrous. Of course, if you are going to stick a needle in there blindly, you better bet your ass, you better aspirate. Imagine you're about to go skydiving, okay? And I tell you, oh, we're down to one last parachute, but the parachute's only gonna work, it's from 1972. I think this is only gonna work half the time. You're not gonna be like, fuck it, let me jump. You're gonna be, okay, I mean, I guess that's the best I can do. Let me take the parachute. Injecting with a stationary bolus technique and not aspirating, to me, is crazy. And that's not what this injector did. But to the people who argue about aspirate, well, I don't aspirate, it's not 100% reliable. Well, I mean, guess what? It's maybe 50% reliable. It may save your ass 50% of the time, but if you're not doing it the other 50%, why would you not aspirate if you are doing the stationary bolus? That's my take on it. You always, if and only if you are doing stationary bolus techniques, you should aspirate, because if you're moving your tip, I don't think you need to aspirate. It negates the whole purpose. What do you think?
So I think that works in lots of the places of the face, but I don't think it works everywhere. I think particularly when you're trying to create a more focused result, like maybe on quite a petite chin, for example, you can't move. You can move a bit, but I think the best example is what we talked about on injectors now, which is the nose, which is there's just less room on some noses to be poking around in lots of directions, and there's very little depth. It's like 2 millimeters to go in and out. Mm-hmm. So you haven't got as much room for that technique. I think all of these things, you've got to think of each one of these ideas as valid and useful in certain circumstances. And then, but really think it through and think about what's the best combination of each. And I don't think there's any way you could argue that moving reduces the chance of volume going into a filler, which is much more important than a small vascular occlusion, which is something I think is worth reflecting on. People get very, very scared of a vascular occlusion until you've had one and dealt with it. And then you think, you know what, small vascular occlusions are not a big deal. It's the big ones that are a real problem. And that's where this really makes sense, which is what are we doing, not to decrease the frequency, but to make sure that when you do have one, it's small, because that is the best way.
Completely
That's more
different,
important.
yeah. But if I could show one more illustration that I often reference is, you know, the movement. If indeed you do pierce that vessel, you're only in there for a split second. There is no way you're going to fill that vessel to create some massive vascular occlusion. Whenever possible, like you mentioned, I think you should be moving. Now, to your point about like the nose, like I agree with you 100%, as we mentioned on Injectors Lounge, you can't do that in the nose. I used to use a cannula in the nose until I listened to Dr. Ayad Harb, his technique, and it made logical sense in that I do microbolus in that area, but it is so small that if ever it were to cause something, it would be so manageable and not enough magnitude to cause any kind of catastrophe.
Yeah,
so
I think in those areas, you've got to just do small amounts at a time. And just that on its own is highly protective. But then you can stack on the other principles. There's nothing wrong with aspirating and doing a small amount, or, you know, moving the needle. I think what Dr. Ayad was saying is maintaining depth. And this is one of the other critiques of the moving needle is sometimes you're moving a needle from the needle tip is going from a position where there's a low probability of a vessel to a position where there's a high probability of a vessel. Like if you did, for example, at the nasolabial fold, going in and out, even the cheek, like the arteries tend not to be on the bone. So you're moving from a position of high probability to low probability. And yes, your VO might be small, but a stepwise improvement on that would be to do multiple boluses deep with small movements. So small amounts each one might be an improvement.
Yeah, agreed. Okay, so on to this next slide that I have here. Okay, so on to this particular case that people seem to be interested in it. Okay, because again, it did represent a massive VO. But again, the starting point, especially for novice injectors, is to understand what actually is happening, to understand in very basic terms. There's no rocket science involved here. Check this out. So if an injector, first you visualize the vasculature, which you cannot predict, all right? Injecting, if you are injecting stationary and you are continuing to push, this is what's happening. It is slowly filling and occluding the lumen of all these vessels and traveling all the way up these connections between these angiosomes, all right? It's gonna go all the way up. So that is the first step in treating a vascular occlusion, is to understand what is actually happening. And what is actually happening is, again, in my opinion, almost exclusively, with a stationary bolus, you are pushing 0.2, 0.3 cc's of a product, which is enough. That's a massive bolus. It might only look like a 60th of a teaspoon or something, but it is enough to fill these small vessels. And in preparation for this lecture, I wanted to do a demonstration with this small silicone tubing. I'll put that in the ultimate lecture. But the idea is that's what's happening. You're filling up that vascular tree. So that's first and foremost. Okay, so that's what happened with this patient. As I mentioned, she injected on the bone, pushed, even with a negative aspiration, pushed. All right. Immediately for the patient, it was painful. All right. But after that, not much. Didn't really think much of it. There might have been some numb areas that she probably didn't even realize. Didn't really think much of it for several hours until around 6 hours later, there was some discoloration with increasing pain. All right. And that's when the injector, to our vast credit, recognized it and did not ignore it. I will say there's another injectable video going around going Instagram and TikTok right now of someone who injected a nose and the whole thing was blanched. And unless I'm mistaken, she just gave some aspirin and saw the patient 3 days later when pustules started forming, which to me is what? So this is 6 hours later, there was discoloration, increasing pain, and she used all of the 3 vials that she had at that particular clinic of Hylenex. And she injected it, here's where I'm guessing, around the commissure, where around the areas of change, and then still not enough improvement, and then went to the ER and was told to seek another opinion, which is when I was contacted and sent this very picture. She presented to me at around the 10 or 12 hour mark. It was a Saturday night, nothing was open, there was no hyperbaric chambers. So at that point, I'm like, do I take this on, or do I send it to some tertiary set? It's like, 9 p.m. on a Saturday night. And again, I know vasculature. So I'm like, yeah, this is not, I'm happy to treat this. But that one of the main key points here is, if there is any question, if there is some pallor, if there is some mottling, if there is whatever, you see how dangerous these things can be. And I never understand it when people are like, well, let's see how it goes. No, it's a filler. You can dissolve it. They can come back in a couple of weeks, you get some more filler. Dissolve it. If there's ever any question about a vascular occlusion, please, people, treat it as a vascular occlusion. To get at these things like a day, 2, 5 days later is catastrophic. What do you think, Tim?
Oh, absolutely. I mean, I've seen so many now where there's this. It's a GP thing to watch and wait, but it doesn't play out very well with the vascular occlusion, because you've got this narrow window where you can really make things better, and the other world where you do nothing, particularly if it's a big one, like it's misery for months, if not years, for people when you have a big one that goes. So there's definitely this window where, even as a cautious clinician, the cautious thing is to be quite assertive and go straight at it and dissolve it. So I totally agree. And I'm a big advocate for just building into your routines, look at how do you make an early diagnosis. There are loads of ways you can diagnose it early. Check your refill all the time, inform your patients. This sort of stuff educates patients. They look for it, and then you need to have a mechanism by which they get help. And then all the systems in the background, including like you did with Dr. Bloom, you have a network that you can call on when you need to, because often with a big VO, you're stocking so much stuff that usually expires because years go by without you needing so much. Mm-hmm. So it makes sense to have that network.
Agreed. Okay, so on to that. I think the very first, the first thing you do is avoid this altogether, which again, if you ask my humble opinion, is to avoid the park and push technique altogether, certainly when dealing with significant boluses. But the next thing, you avoid it. And then number 2 is you be prepared for if and when it happens. You have your kit. And what should people have in a kit? This is not, like, a lot of people agree with this. All right, as you mentioned, Hylenex. Now, it's different in the United States versus Europe and beyond. Here in the States, we have 150 unit vials, as you see here, which is, from what I understand, you guys have 1,500 vats of this stuff? I'm jealous, because
they're
here
cheap as well.
Are they really? It just pisses me off. Everything here is like 4 times as much.
Pounds. Yeah.
Us dumb Yankees, they charge us don't get me started. But okay, so here, as you can imagine, it's a real problem for United States injectors, because people think, okay, I'm going to have 1, 2, 3 vials, as I used to when I first started doing this. I'm like, oh, I have Hylenex, I'm safe. No, you have to be prepared for the massive VO. So the question here in the States, it sounds like it's easy in Britain, just have multiple vats of this stuff, take a bath in it. But here in the States, it is a little bit at a premium. So I would recommend to my fellow United States injectors that you have at least 10 of these vials. Now, you might say, well, that's not enough. 1,500 units isn't enough. But to your point, how much are you going to stock? I think unless you're in the middle of bumblefuck Nebraska, that you should have 10 vials and a network, like you said. This should be part of your preparation plan, to have colleagues that you've reached out to tomorrow, today, that, hey, we should get into a little thing where if any of us have an emergency, all of us pull our Hylenexes, so I have 40 vials if I need it. I'm not saying, some people, like, it's very much a chest beating thing. Oh, I carry 50 vials, or I carry 40. Good for you. If you want to waste all that money, I think it's much more practical, as long as you live in a major area, to have friends that can help you out. So yeah, I wish we had 1,500 unit vials. I think it's important to have an EpiPen as well in your kit, just in case you have an allergic reaction. But the recommendation is not to do allergy testing. Obviously, you're not going to not inject someone and wait for an allergy test when you have a real emergency in front of you versus a theoretic one. But why not back it up by having an EpiPen in that kit? I would say nitro paste. Now, this is a little bit controversial, I believe, because recently the recommendations have changed from CMAC, was it, or some consortium no longer recommends nitro paste. I use it in this case. I will continue to use it because, these vessels, arterial vessels have smooth muscle in them, and that is how you control contraction or constriction and dilatation, is the smooth muscle. That's what nitro paste does, nitric oxide. It relaxes muscle. So it only makes sense to me to use this. We use it all the time in plastic surgery. Something looks dusty, throw some nitro paste on it. Nipple looks dark, throw some nitro paste on it. So I used it in this case, and I think it makes a difference. Any thoughts on nitro paste, Tim?
Well, I mean, I've never had to use it because I usually would keep someone with me until it was perfused. But I think the thing I heard was the dilation of it dilates veins more than arteries, and that was causing some sort of congestion. The theory being, and some of the studies on surgical flaps thought that it was better with Viagra, so people were switching to using sildenafil instead.
Here's where I get a little bit. I don't know the answer, and I don't have all the answers, but I do think there's lots of conjecture, there's lots of discussions in boardrooms and stuff, and like without the science behind it, we just don't know. So who's to say that nitropase is any bit inferior to sildenafil until it's studied in this population? So I don't know.
Yeah, well, like we talked about in Switzerland, the evidence in our sector is unfortunately relatively appalling. So we actually don't know even that hyaluronidase dissolves will help you prevent necrosis from a VO, because there's just not enough data. We just have to work from first principles and make the best, which is why this kind of discussion is so useful, because other people think differently from their experience.
Yeah. So what else is in my kit? Aspirin, of course, we all know and appreciate that. Aspirin, prednisone. This is another I believe is no longer recommended, but I'm still going to use it. I guess the concern is about infection. Look, if you're talking about infections, then you're already like, you're already like 3 steps down the line where there's necrosis and look, I want prednisone on board because I want to minimize inflammation and swelling. The more swollen a tissue bed is, the less flow there's going to be in that capillary bed. Ultimately, what you want in your kit is all things that are going to help increase flow to the tissues. And to my thinking, prednisone is going to decrease inflammation. It's going to decrease extravasation of fluid, decrease pressure. It's going to prevent stasis. So I don't see any reason why not to use it. Any thoughts?
Yeah, I mean, I feel similar about it. That you should have it, but most of the effort should be towards not needing it in the first place. Because by the time you're on the back end of these other things, it's gone a bit far. So I've honestly never used them for a VO but in our clinic, I think we've had 20 altogether, and they're all diagnosed and treated immediately over sort of 10, 15 years. And it's never gone beyond just dissolving it. So we have all the stuff, a very similar list to yours, but I would encourage people to build systems that don't allow you to get too far down the list. But it does make sense,
I want to come back to that in a little bit. So lidocaine. Unfortunately, at my clinic with our flood, we didn't have lidocaine without epinephrine, so I did not have this available. But again, lidocaine 2%, lidocaine 4%, lidocaine is a vasodilatator, all right? It is going to relax the smooth muscle the same way that sildenafil will in a different via a different pathway. So lidocaine, why not? It's going to decrease their pain. It's going to dilate the vessels. Why not inject it? And so I would highly advocate having 2% or 4% lidocaine. And then, like you mentioned,
for me, to be honest, that's new to me. I hadn't used that, so that's learning for me. I hadn't thought about using it as a dilator. I think it's very helpful to get the patient through the trauma of repeatedly injecting them. But blood flow is cool.
Yeah, it's funny, and this comes from my microsurgical training, because we would do these flaps, we'd sew these micro vessels together, and we had, okay, hand me some papaverin, hand me some 4% lidocaine. We had all these things that you would sprinkle on top of the vessels, trying to get them to dilate up so that the anastomosis would work. So, all these things, you want to increase pressure behind and then decrease resistance, all with the aims of increasing flow. So like you mentioned, numbers and protocols. I can't stress this enough. It's not just about having your little handy dandy kit and your heating packs, as you see here. You have to have a network built up for extra Hylenex if you need it. And more importantly, what are you going to do? Like hyperbaric. Do you have a hyperbaric number? What if there is, an ophthalmic? What if their vision starts to go? Or do you have an ophthalmologist on call? Not that that's going to change anything, but you have to have the protocols, and you have to go through the protocols with your staff and do like a trial run, do like an emergency drill with a VO. I think that's very important if you're doing a lot of injectables. Agreed?
Yeah, I really think it's important, because this stuff's so rare. You can actually go, like for me, it was 10 years before I had a VO. If I hadn't thought about it regularly, but it's very easy because I was already teaching, but it would have been a complete shock to the system. So you need to do something every day that reminds you of the process. And the easiest thing is to teach your patients little bits of it as you consent them.
Yeah. So first off, okay, now that a patient comes into the office, all right, assessment. Can you see this okay?
Yeah.
Okay, so assessment. First off, documentation. I spelled that wrong, sorry. But it's important. The last thing you feel like doing is taking pictures and videos, but of course, that's what I did. You have to remember, not only to medically legally protect yourself, but to look back on the next day when you see the patient. Hey, was this area dusky? Is this dusky now? Has some embolus propagated distally? You need to compare how the patient was at time 0 versus time X, Y, or Z. So documentation is incredibly important. So check this out. So we're going to check capillary refill. That was good. That was good. I don't know if that's showing. The nose is good there. Now look, there's livedo all over these places, but the flow is good. Capillary refill under 2 seconds. I'm not worried about these areas. Cheek is hyperemic. I'm not worried about this area. There's changes, but that's not going to necrose. If I send her home, that's not going to necrose. A little bit sluggish there, okay? But when we get here, now it's starting to get really sluggish. We're talking cap refill of 3-4 seconds, all right? Here, as I'm getting more concerned, I'm going to hold pressure longer to really get a good sense of capillary refill, all right? And this area, now I'm really concerned in this area because this area is very slow, the cap refill. And one could argue I should have pressed it longer, but guilty, all right? Over here, very slow. So cap refill back on the nose, this is good, okay? So an important distinction here. Let me just take photos, take videos, and sensation testing, okay? That's part of what I did before I did anything. I documented where the patient was able to feel. Do you feel here? Yes. Do you feel here? Yes. Do you feel here? Yes. Anywhere where she could feel, I am less worried about. Why? Because a tissue without blood flow does not have sensation. How many times have you woken up on your arm at 3 a.m. like, oh shit, I can't feel my arm? That's what happens. Like as soon as you restore blood flow, sensation comes back. There's no such thing as ischemic sensate tissue. So all these things go into helping me assess what's going on and risk stratification. All right, so risk stratification. This is very important, especially when dealing with limited amounts of resources. I only had 10 units of Hylex in my clinic that night. All right, so what am I going to do? I'm going to look, and there's changes up at her glabella, okay? Do I care about them? Not so much, because there was amazing capillary refill. Just because there's changes does not mean there's going to be necrosis. Now, I'm not saying to ignore it altogether, but I'm saying this helps with the risk stratification. So there's changes here, but as we started to get closer to the lips, now there's livedo and there's some duskiness. And then on the lips themselves, there was pallor. These are 3 different areas. All right. So if I'm going to imagine this, I'm going to imagine everything else is green, pretend. All right. But the yellow area requires some thought, some treatment, but not the same amount of treatment. Once you get into the area that there is livedo and pallor, it starts to look a little bit less regular, then I'm going to be more concerned about it. And by the time it gets to the red areas where there's pallor and there's no capillary refill, that is where I want to focus most of my effort. So risk stratification for me is really about figuring out where you're going to spend your resources. I'm not just going to blanket carpet bomb everything with the same amount of Hylenex, then I'm going to waste it in areas that need more. Her glabella didn't need anything. You saw how quickly it refilled like that. I'm still going to give it a little bit just in case, all right? But so again, I'm looking at her again up here at the glabella. There was some changes, but I showed you the capillary refill was excellent. She was sensate there, excellent sensation. That's just a little hyperemia. Out here, just a little hyperemia. I'm not really going to treat that. I didn't treat her cheek at all because I wasn't worried about it, even though there's some changes present. Okay, but then once we get here, that's like the orange zone, and then here was where I was really concerned about, and that is where I really want to flood the tissues. Okay, so with the actual reversal, how am I going to do along? I'm going to go along the entire path. I want to back up because I want to get your thoughts on this. Like any thoughts on this risk stratification?
Yeah, I think it's a really important point around the resources is that if you run out, and this happens to injectors, like sometimes it's 1 o'clock in the morning and you run out because you've been at it for 4 hours and so it's important to prioritize. I had a very strange case once where the whole face was mottled, and that was obviously kind of terrifying, but similar idea. But well, I found it quite useful doing a cap refill on the whole face, kind of strange, but compress the whole face and release. And it all basically ended up with the last place to refill where we targeted most of the effort. And I think it was spasmodic vessels that caused the mottling, but it really helped to know where the priority is. So I think that's your point, which is really important when it's a big and a complicated VO like this one.
Yes. So next up, the actual reversal. How am I going to do it? And again, just in all cards on the table, complete transparency. I'm not saying my way is the right way. If you talk to yourself, I want to see what you think. If you talk to people on the CMAC panel, they might think this is completely wrong. If you talk to someone who's an ultrasound proponent, they might think it's the wrong thing. My particular way I approached this case was based on all the things that we already talked about. I'm going to reverse along the entire path. All right. I visualize the vessel. All right. But more importantly, I want to visualize the end organ. And we're going to get that little tricky quiz that I did on Instagram that we may disagree about, but that is my whole point here. All right. Perfusion is an end organ phenomenon. You could block this artery here, and if these vessels are patent, if these vessels don't have filler in them, they are going to be just fine. Why? Because collateral flow. The face is extremely redundant when it comes to vasculature in the vast majority of patients. So even if this, let's say, filler reached to this area, if it didn't reach to these microvasculature, to the capillary bed, to the end arterioles, it doesn't matter because you're going to have collateral flow, which is going to reach these areas. Okay, so that's one way to approach this is, let me get back to that. So I'm going to use all 10 vials that I have at my disposal according to this risk stratification map, all right? And I'm going to do it until perfusion is restored. And I'm not going to go home until I have at least an initial perfusion restoration. So here is what I ended up doing. All right. She had a massive VO. It went all the way up to her glabella. So what did I do? I had 10 vials. I looked at the risk stratification. I said, okay, this area here was the most dire. The nose was kind of dire as well, the lateral ala. So I didn't want to ignore the source vessel entirely. And what I did, I stuck the needle in, and I'd recently saw Julie's post on, hey, if you're in there, why not aspirate and see if you can get into the vessel? And I tried 2 or 3 times, no luck. I wasn't going to let that hold me back. So I put a big bolus right there to potentially diffuse into the source vessel where the initial bolus was. I went to the big bifurcation point where the facial goes into the superior and inferior labral arteries. I went to another major bifurcation point where it turns into the angular artery. I went to, so then I went to these problem areas and I put a bolus directly in the lower lip. I did another bolus here, and I actually went around to the other corner where there were changes. And then I got a cannula, and then I started fanning. When I was doing the boluses, I want to flood the tissue as best possible. So I started low, and I pulled out and injected the whole way. 1 vial here, 1 vial here, 1 here, 1 here, 1 fanned there, 1 there, 1 there, 1 there. And to the point of the glabella, didn't want to ignore it completely, but I did 1 up there just in case. But I wasn't really worried about this. So the vast majority of my efforts were focused around here to flood the area. And that makes me feel good because capillaries some of them are like 1 or 2 cell walls thick. It's going to easily penetrate there and clear those. Even the bigger vessels, De Lorenzi's studies show that if you put even the facial artery filled with gel into a vial of Hylex, it will perfuse. So these walls are permeable to some degree. One of the points I want to make is I think a lot of people, especially new injectors, they focus on the source area because, oh, this is where I caused it. And this is where the big vessels are that I know and can picture, and they start focusing their effort here, thinking it's going to arborize and treat all around here. That is not the case. You have to flood the end, or again, ischemia is an end organ problem. So my personal approach is to flood the end organ, to flood the capillary bed, to flood the arterioles. And I'm not even so much concerned about this vessel here, the facial, because there is so much redundancy to this tissue. Any thoughts?
Yeah, I'd really like to ask you about what the impact you think, because you haven't mentioned massaging yet. Now, massaging for me, when you're thinking about a load of filler in a bigger vessel, which isn't necessarily stopping the capillaries perfusing, and then you start massaging, but you're massaging into the smaller vessels. But then at the same time, the smaller vessels, it's going to be easier for the hyaluronidases to get in and dissolve the products. But what are your thoughts on that? Because for me,
I love that you brought it up. It just shows we think very similarly. If I might, I want to hold off just a little bit till we get to that slide, 2 or 3 slides from now, because I have a slide just dedicated, I think, to massage. I think massage is incredibly important, and I don't hear people talking about it a lot when it comes to this stuff. Everyone's very excited about, cannulating the artery or using their ultrasound and doing fancy things. Like, I hear not a lot of people mentioning massage. I think it is incredibly important. So I want to show that in just a second, if I could, because I think I have a slide on that. But this I really like. How do I know if there's flow? And even as a plastic surgeon who's been doing this for like 15 years now and that's all we do is try to assess flow in tissues. Is this thing perfused? Get a call from the resident at 2 a.m. This flap doesn't look quite right. Is it perfused? Is it not? Who knows? Like, even I get confused, having done this for years and years, assessing perfusion. It can be confusing. So one thing I want to show everyone, how do I know if there's flow? Like you mentioned, color, that's obvious. Okay, if it's red, it's good. All right, capillary refill, as we mentioned, in general, there's a very general rule if it's over 2 seconds, but even that is not always black and white. Like, sometimes it's sluggish and you don't quite know if it is perfused or not. And this is, so right here, here's how she looked after my first night of dissolving. All right. Now, the untrained person or the trained, this is confusing, might look at this and be like, oh my God, that's still pallid. There is still pallor there. It doesn't look the same as over here. This is hard. I don't know if it's showing up in the picture, but what in person I could perceive was where when she came in, that was white. And when she left even, it wasn't pink like everything else, but it was pinker. It did have some pinkness to it in a backdrop of pinkness with this overlying pallor. There was a change, there was redness, but it is confusing. All right, now watch this. Cap refill test in someone who's already been dissolved. Right there. That doesn't look great, right? I mean, it doesn't look normal.
No way.
Well, down there, that was good there, but that top lip, am I going to do that again? I think I am. Let me see. Why am I taking so long here? All right, but did you see how, like, down there, you see that? You see how long that took to refill? That's confusing. Even to me, a self-proclaimed expert in tissue perfusion as a plastic surgeon, that's confusing to me, this whole scenario, and I don't know if I'm done yet. And do I send this out to an ultrasound person? Do I let them go home? Do I stay like through the night and like travel around trying to find more Hylenex? And this, I think, is so simple, all right? How do you check? Here's how I check. Get a goddamn needle and pierce the tissue. I don't know why people don't do this. Now watch, look close. I'm sorry, blurred out. That focus wasn't good here. But look, that, I don't know if it shows, but that is a dot of red blood. All right? And I might help it a little bit just to show.
How do you know it's not venous? Because
it's red. I mean, it's bright red, and that may not be showing there. But number one, when I just let go, venous blood, when there's venous congestion, it bubbles up dark immediately because the pressure is high. But here it was red. I know that might not show through, but that's how I know tissue is perfused. Like, I don't need an ultrasound. I wouldn't even trust an ultrasound for the end capillary bed. There's nothing better than pricking the tissue. I don't know why we don't talk about this more often. All we do is stick needles into people's faces all day. Why not just prick it? If it bleeds red, there is blood flow. Now, I'm not saying
very useful. That's very useful for dark skinned patients as well, and a lot of people struggle, and that's the other thing you can do.
Yes, that's a wonderful point, because in the end, your eyes, look, either you're using your eyes to look at an ultrasound screen, or you're using your eyes to look, is that bright red blood? And that was bright red blood. Now, I'm not saying that I'm going to be like, oh, whew, we saved this one. I'll see you next week. Not at all. But this helps me to understand, okay, there's bright red blood there. There's oxygenated blood getting to this tissue. We are initially, there is blood flow to this. This is not as dire as it was just a moment ago. So the limbo zone. I want to make this point here, and this goes along with the massage. This is also a plastic surgery or burn surgery concept. The zone of, if someone gets burnt right here, all right, this tissue is gone. It's a zone of coagulation. It's necrotic. All right, you're done. All right, but there are two different zones that are very interesting and relatable to this topic. There is the zone of stasis and the zone of hyperemia. All right, the orange zone is the zone of hyperemia. That tissue is going to be fine whether or not you do nothing and send the patient home and don't see them in a month. It is the green zone that I will now reframe as the limbo zone. That tissue is in limbo. And depending upon what you do over the next 24 to 48 hours, that tissue could go one way or the other. It could go red or it could go orange. And so this is why it's so important to your point about things like massage and things like hyperbaric oxygen. There is a window after which you have restored flow that I'm not going to pat myself on the back and just like, see you later, patient. There is a window in which not just dissolving, but the other things that you do matter. So here's how she looked when she left my office that night. Okay, this is hyperemic, but it's fine. Hyperemic, all this hyperemic, but it's fine. All of the tissue has blood flow. I pinpricked it all. And she was bleeding everywhere. But still, this area was a little bit sluggish, a little bit discolored. So I'm like, you know what? I'm going to see you back in the morning. All right, now if it were during the day, maybe I'll see her back like 3 hours later or 6 hours later. But look, there was blood flow. I was comfortable enough to see her back in the morning and a closer look there. All right, see right there? That was bleeding when I stuck it. She had not perfect sensation, but some sensation there. So I'm okay that there is flow, but there is a timeline in which it can go one way or the other. So between the first and second visits, here's what I tell them. Massage, to your point, I call it CPR for the skin. All right, and it's because, look, this is the end organ, the capillary bed. It is stagnant to some degree. There's swelling, there's microclots. That blood has been stagnated. That's what happens. It clots in the lumens. And what you do with CPR, you take someone whose heart's not beating and you're manually pushing to manually push the blood around. I think it is incredibly important. And what I told this particular patient is, look, I massaged in nitro paste that night, all right, all over that area. It's going to dilate all the vessels. And as I was massaging, I massaged in nitro paste. And I told her, set an alarm every 2 hours, wake up and massage your lip. That's going to be important because not only if there's some area of stagnation that's not getting that blood flow, I want her to be making that blood coming from the oxygenated areas and pushing the stagnated blood out. Look, there's no evidence for any of this stuff, but I do believe that massaging the skin does make a big difference, along with nitro paste and maybe sildenafil and prednisone and hydration. That's the other thing. If someone's dry, you're like, oh, I'm all nervous, I have a vascular occlusion, I'm not going to drink for 12 hours. You need to get their pressure up. If they're taking a high blood pressure medication, I'm going to tell them, don't take it tonight. I want your arterial pressure as high as possible. I want you hydrated. So these are all things that can potentially take the zone of stasis and make it something that's going to survive this whole ordeal. And ultimately, even with that massive vascular occlusion, she barely had any pustules. We got her through this without anything. And I think it's because all these different things that I had her do, plus the hyperbaric oxygen. This stuff is so important. I think some people think there's some question to it. I used to run a hyperbaric clinic. Like, it works. It perfuses tissue that is on the edge, all right? This tissue that's in limbo, you don't want to send them to a hyperbaric that's one of these soft inflatable chambers that only has 1.5 atmospheres. You want to send them to a real clinic that has a chamber like this that can go up to 2, 3, 4 atmospheres if needed. But this is one of the things you should have in your box. You should absolutely send your patients 1 or even 2 times a day for hyperbaric during this initial ordeal. Any thoughts?
Yeah, I mean, I was one of those who I'd read some papers and it was kind of questionable, and then I put a patient in hyperbaric oxygen, and the difference was so amazing that I was completely converted. I mean, it just made such a huge difference so fast that I 100% believe it.
Absolutely. And I will say, even if there weren't any evidence, I would say, look, this stuff matters. I feel like, what time do we start this live, Tim? I feel like we started like 4:05.
Yeah, we're 56 minutes in, minus
Okay,
the.
so we only have a couple minutes left. So I'm going to blow through this real quick. Follow up. I know recent recommendations are to see her hourly. I think that's a bit much. Like, as long as you have reestablished an initial flow, I'm going to see her back in 3 to 6 hours. I'm going to consider referral to an outside ultrasound expert if there are problems. Like, hey, I'm not so egotistical to think that I have all the answers. I don't think you need ultrasound in the vast majority of these cases, but if there were problems, hell, get someone involved who is an expert. All right, and this is a caveat here. You don't want to, oh, someone in town has an ultrasound and she's used it. She's been to a weekend course and does it once a week. No, I'm talking like experts. You know, like Dr. Stella, like Danny Scher, like Steve Weiner, like people that like do this all the time. If you have one in town, send it to them. So just so we're not skipping this, to your back to the initial question, I said that if you were to actually remove this artery, I would not worry at all. People do it all the time because this is the face. All right, this is a plasticized version of all the arteries. Look at all of this redundancy. All right, and not for everyone, but the vast majority of patients have redundant facial vasculature to the point where we do flaps all the time in plastic surgery. We take that artery in nasolabial flaps based superior or inferior. We harvest it, we sacrifice it. The nose doesn't necrose, the lips don't necrose. We take the artery with the flap. And nothing happens, again, because it is so wildly redundant. And look, I want to let you finish this out because I want to hear your thoughts. But again, I have a bunch of illustrations that we didn't even get to. And I want to make a follow-up lecture to this. No charge. I'm not looking to make money off this. Just send an email to Jillian, Jillian, at Dr. Subbio. Just put your name and put vascular occlusion, and we will send you in like a week or two when I actually make this lecture and record it. But so back to you. I want to let you get the final thoughts here.
By the way, I think we might be able to go over an hour because I've done that a few times. It lets you go over.
Oh, really?
But if you have time, we can always restart it if it goes that way.
Oh, yeah.
Anyway, so the first thought I had was, I think like although that theory, because a lot of that comes from this idea of the redundancy, and I think what your images highlight is there's this mental model of vasculature being like a tree, and it really isn't like a tree, because a tree anywhere on a branch, you cut any branch, the rest of it dies. But it's just more of a series of loops. So if you think of the vasculature more like a series of loops like that, where there are these connections in between that allow tissue to survive. But the question I have is like, how strong are those connections? Because it seems to be that most vascular occlusions that I see have delayed capillary refill. It's not zero capillary refill, and you still get necrosis. So how are we to know what's that? How does that fit in with this model of it being okay if it's in a big vessel? Why do you see that so often, and then you get necrosis as well?
I think,
if it's not in the capillary bed, that's the key thing.
Well, I think the last thing you said, because it's not in the capillary bed?
Yeah, if you've got a delay in capillary refill, then your capillaries have clearly got blood flow in them, but it's not enough blood flow. For me, that's the gray area of whether you can block an artery that causes, because obviously you've got these vessels which the connect the vessels and can develop the choke vessel, but it takes 3 days for them to develop. So what's actually going on with, like, how does this play out with your model? Because in my mind, if you get a delay in capillary refill, the fact that it's in the artery, there still isn't enough oxygen getting into the tissue.
So if I may, just real quick, and again, we might cut off here, but like, a lot of people, choke vessels are a little illustration I did here to show you to show people what a choke vessel is. Now look, here is a vessel, and it perforates the tissue and it supplies in a arborizing pattern. All right, this is an angiosome or perforosome where it perforates. That is a territory supplied by that vessel. Okay, and if you were to cut it off and there were nothing else, that tissue would die. But think of that big net in the face that I just showed you. All right, there is always a adjacent vessel, an adjacent perforosome that is sitting right next to each other, all right? And the connections, these little vessels here are the choke vessels, all right? And they act as a backup. If ever do I have the right, so let's say, you know, so if ever you block off the blood flow to this one, these little vessels here are going to dilate, oh shit, here. Anyways, I don't know why this isn't working. But they're going to dilate up, and these are going to allow flow between one and the next. That is one way you have redundant flow, even if there is, you know, filler clogged here, all right? If the vessel itself is filled with filler, there's no oxygenation of that tissue. So that's to the point, this is redundant. So forget, even if this is blocked, but this is clear, it will fill from the sides. That is an angiosome, and the choke vessels here are what dilate up. There we go. Here's what I wanted to show. All right. So right here are those little vessels, and they dilate up. Like you said, that takes time for them to dilate, but there is connection. All right. So the initial connection will allow some blood flow from this side, but then there's one over here, which is going to add some from that side. And there's probably a redundancy, a linking vessel from here to here. There's so many different paths for blood to get to this tissue, in particular in the face. So back to this example. So let's see, so there's the nose. This is this area. Now let's say it starts to fill. You start to inject here, all right? You're filling. I don't know if this is showing up here. Okay, so you're filling there, and it continues to fill, and now you blocked all these major vessels. If this were the case, to that little quick trick quiz I did, this would still be fine. All right, because the microvasculature, all right, the microvasculature is still going to allow all this redundancy to fill in from the sides, unless you continue to fill, and now the area is filled with filler itself. All right, now, no matter what you do, no matter how many vessels are coming at it, the end organ is blocked, and it will, it's filled with filler. It will not oxygenate no matter what. So it really depends upon how much is perfused. Like back to that point, like if you just start to inject a little bit, back to the point about how much we're going to inject, a little bit is not going to do anything to anyone. All right. And if this is, you know, forget other little perforators, but if this is where the filler is, it's not going to do anything. If this is where the filler is, these beds are still fine. They're getting collateral flow. If this is where the filler is, now we have a problem. And if now the secondary flow, if you have so much flow that the two angiosomes are now filled, now you have a real problem, okay? And now this is why flooding is so important. You need to open up as much as you can, and that's why I think carpet bombing the area is going to be the best solution.
So the thing that I still struggle with, that I don't get about this, is if there's a delay in capillary refill, it means you have blood flow, but you still get necrotic injuries from that, which means the theory is sometimes true, but on the peripheries it won't be true. Like you can still have angiosomes that are working, but there just aren't quite. There's not quite enough blood. This might be how.
Here's the thing, Tim. Like, and this is where it gets so confusing. Capillary refill is so difficult to assess. I've done things where I've taken a tummy tuck specimen after a tummy tuck, put it on the table, on the back table. It's now detached from the patient, and I press into it. And I let go, and it blanches, and it fills back. I think most instances of necrosis after sluggish capillary refill are one of two things. Number one, injury has progressed. Something has gone distal, or the swelling has progressed, or the stasis has progressed. Something else has happened. You haven't recovered it sufficiently. It's been in that limbo zone where you're like, oh, see you next week. And it turned the corner for the worse. That's one thing. Or number two, it never had good capillary refill to begin with, because it is confusing. Because like I said, I've even been confused on a back table pressing. Just because you press, something blanches and then refills doesn't mean that it's actually good refill, which makes everything even more just confusing, which is why it's like, fuck it, carpet bomb it, you know?
But it does mean that the capillaries are empty, doesn't it?
What means it?
If there's cap refill, there's no filler in the capillary.
Yes. So then then it is also, I was talking about that to Danny Soares about this. If you guys don't know him, he's a brilliant facial plastic surgeon in Florida, Soares, Danny Soares. He was talking about, this is also, perfusion matters. Like, how good is the perfusion of the, what's the blood pressure? Is there, this is where there's so many factors that go into it. Let's say there's no filler in there. Maybe it has, hold on a second. Hey, buddy. What?
I see your face.
All right. Yes. Okay. So, where was I? So, I want to like flesh that idea out more. If there's no filler in there and there's not good capillary refill and it necrosis, that could be one of those rare instances where there's not enough redundancy. He brought this up to me as well. Like, I think you're overestimating the redundancy of the facial vasculature. Like, this is where it all gets hairy, and this is where it's like we're talking like in such nuance that it's who knows. That's where I get confused, where we start to get into such conjecture that it becomes abstract.
Yeah, well, this is the fun bit. I for whatever reasons, enjoy thinking about this, and but it's still, there's all these things, like whether you aspirate, bolus, all these things are probabilistic things, and you're dealing with multiple variables and trying to make sense of. In fact, even the anatomy of the face, we're trying to put a false bracket around what the facial artery is, but really it's just a whole bunch of connecting vessels, and that, that's our job, is to try and compartmentalize things that are not actually compartmentalized.
Yeah.
They're all...
And the problem, as we've already said, the research is, it's hard to study these things. We don't have the tools to study them. So it's kudos to the people who are tackling it.
Okay. So did you organize for your child to come in just at that moment when I stumped?
I'm like, bring CJ, bring him in.
Well, I'm glad we got to that, because that's like at this end of, like, that's the best kind of discussion, is where you're left wondering, and
Yeah.
certainly more to think about. And I think you definitely got a lot of people thinking with this idea that you can remove an artery and still have blood flow. But it's this gray area of exactly how much. It's more of a physiologist as opposed to a surgical approach. Like, the physiologist would say there's a downslope of oxygen supply, and once you go past a critical moment, it's going to start to necrose. But then, let me ask you one other thing if I've got you, because I think it's related. Yeah. Why do you think? I think that a lot of tissue seems to necrose more on the surface than deeper on. I don't know if that's because the vessels are getting smaller and it's the same idea, but they're very, like, most of the necrotic injuries, you don't lose a whole clump of tissue. It's superficial and actually heals quite well. And
I think exactly what you said. I agree with that. I think it's because the skin is the end organ. Beneath the skin, the vessels are more abundant. Your arterioles are everywhere. The plexes are everywhere. On the skin, that is the ultimate end organ. Everything is so tiny and microscopic by the time it gets there that the flow is just less. The pressure is less. So
okay.
it's just more fragile.
Yeah, that makes sense. I suppose we should wrap it up. It's been a joy talking to you, and I think everyone is just overwhelmed with how much value you've added. It's really amazing. So make sure you follow Dr. Subbio on his page, this page we're on now, Injectors Lounge. Email, you're going to get a lot of emails.
It was like an hour ago. I'm like, we should put an email up to, if anyone wants that lecture. But no, Tim, if I could real quick, just to return the compliment again, like what you were doing for our field with all the discussions you were prompting and all the education and all the interesting input, and Miranda, like from the other aspect with, for the business and for the marketing, like you guys are like a powerhouse. You are like, I envy you guys in the best kind of way. So thank you for all you're doing.
Oh, well, then I'll do the same to you and say, when I was looking over your page, I was just so humbled, because every single post is this killer. Like, we produce a lot of content, but you produce these little beauties that just fly. I just think you can learn so much just from seeing how you're doing it. And it's not, you can't emulate it, but certainly be inspired.
Look at all this love. Look at all this love. Oh my God.
Yeah. Oh, let me challenge you to the other thing, which we might disagree on, which do fillers lift? I want to have that debate with you. I'm going to come out and say it. And I feel like I'm coming out of the closet now, because most people, once they've seen your devastating posts, they'll just be like, I'll just lay low on that. I won't say much. But secretly,
Tim, I don't want to half-ass this. Let's save that for another day, because I want to like.
Oh no, not today. Yeah, no.
A good discussion about that. Fillers do not lift. No, in my opinion.
Okay, yeah. I think they do. I think they do. It's nuanced, but they do. But I think we should save the detail for another day.
Well, it's not easy being wrong, but yeah, let's we'll do that another day.
Yeah, no. But anyway, there's your challenge. The gauntlet is down. I'm gonna be the guy who says I'm gonna debate Subbio on that, and we'll see.
Worst decisions have not been made. All right. Well, again, thank you for your for having me. Thank you for doing this. I've just enough. I'm happy to have talked to you. So thank you. I really appreciate it.
No, it's been amazing, and I'm sure everyone is super. In fact, I've seen the comments; they are super grateful. I think you've made a real impact with this. It's a fantastic case. You know, that feeling you get when you see the patient back to health is such an amazing thing to be able to do that, and then to share it as well is fantastic. So thank you very much.
Great. Thank you. All right, man.